Okay, streaming start.
Okay. Hello everyone. All the honorable speakers online. I'm Dr. Wu from National Taiwan University Hospital. It's my great pleasure to co-chair these sessions from the ABYS Cloud Forum of Cardiovascular Disease Series with Dr. Relato from Philippines. And we have Professor Sungro, Professor Echo, and Dr. Shah from the Asian Pacific. We have a lot of experts tonight, this afternoon, to discuss with us about the topic of innovative breakthrough in ESC 2024 with some of the late-breaking trials. I think we'll talk about the Asian Pacific points of view in some experience session this afternoon. And this is the annotation. In the London ESC 2024 annual meetings, we have a lot of innovative studies have published to confirm, question, and even with some therapeutic concepts in cardiovascular disease. And we will review about the revascularization strategy in older myocardial infarction and about the use of beta blocker after uncomplicated myocardial infarction, and also about some new trials regarding GLP-1 receptor antagonist and the MRA in the field of HFrEF, HFmrEF, and HFpEF. I think a lot of trials will be discussed in these sessions, and we will share our opinions with the experts from all over the Asian Pacific. I'm sure that we will learn a lot and we can discuss a lot of interesting issues this afternoon. So I'm Dr. Wu from National Taiwan University again. And the co-chairperson is Dr. Relato from Philippines. And this is the disclaimer. The content of this webinar is copyrighted by the ABYS and should not be distributed without the prior permission of the ABYS. The views and opinions expressed in the webinar are those of the faculty members and do not necessarily represent those of the ABYS. Housekeeping, the living streaming content of the webinar will be made available via ABYS Cloud, ABYS Facebook, and the YouTube page. So let's get started. It's my honor again to introduce the first speaker, Professor Sungro from Pakistan. Professor Sungro is the coordinator of the Go Red program for women in Pakistan. She's also the chairperson of Scientific Cloud Council of Women with Heart Disease, and she's also she was also the former president of Pakistan Cardiac Society. So I think she's a great professor, the great experts to introduce the following topic: the inflammation, cholesterol, and the lipoprotein to 30-year cardiovascular outcomes in women beyond traditional ASCVD prevention. Let's welcome Professor Sungro.
Thank you. Hi, everyone. My name is Dr. Khalda Sungro. I'm chairperson of Scientific Council of PCS for Women with Heart Diseases. And my topic is introduced by our chairperson is on inflammation, cholesterol, lipoprotein A to 30 years experience and with cardiac output, cardiovascular outcomes in women beyond the traditional ASCVD prevention. There is nothing relevant to disclose for this presentation. Approximately 1 in 3 women dies from the heart diseases globally. Higher incidence of heart diseases in women than population in South Asian countries in Pakistan, India, and neighboring countries. Despite of the fact that CVD mortality in women is declining in the Western countries, but it remains the #1 cause of death in lower income countries of the Asia Pacific. Apart from studying the other specific regional and traditional risk factors, recently studies assessed that the circulatory inflammatory biomarkers like high sensitivity T-reactive protein, LPA, oxidized LDA-C contributes independently for the atherosclerosis. Together, they showed the predictive power of long-term CVD with a comprehensive risk profile, whereas imaging techniques play a role in further diagnosis. Women have a unique inflammatory response due to their hormonal influences. Early life intervention shows an important risk reduction in CV health and progression of the CVD as a chronic inflammation plays a role by endothelial dysfunction, plaque formation, and thrombus, thus leading to cardiovascular disease and CAD and its progression. Inflammatory biomarkers like LPA is a specific protein which is called apolipoprotein A, containing both large and small apo, which carries cholesterol and LDL-like particles. Threshold level of is associated with CVD risk is more than 125 millimole, and levels are primarily determined by the genetics, varies with individual to individual. Coming to the C-reactive protein, another biomarker of the inflammation. A study was conducted by Paul M. Rutger and other co-authors for 3 years that shows that women who developed CVD events had higher baseline CRP level and 5-fold increase in the risk of vascular events and 7-fold increase in the risk of MI or stroke. The study was suggested that the CRP is a strong independent risk factor for the CVD and adds to a predictive value of risk model based on any factor alone. Coming to the LPA and women and heart attack ratio. A study was published in JAMA on emerging biomarker LPA level in 126,000 participants in a data pool from the 36 prospective studies that shows that elevated LPA level were linked with the higher CVD, risk of higher CVD events, heart attack 13% and 10% risk of the stroke. LPA levels were higher in women, particularly after the menopause. This 10-year study reinforced LPA as an independent risk factor for the ASCVD and suggested the need for therapies specifically targeting LPA. What are the limitations of already done studies on this subject? Keeping in view of the limitation of the current studies, which has studied traditional risk assessment often focused on the short-term predictions, and risk assessment tool may not be fully captured the nuisance of women's CV health. So the studies were conducted by addition of the inflammatory markers and LPA as a risk factor for the more effective personalized prevention strategies. Thus, a study was again conducted by Paul M. Rutger and authors for 30 years period, which was showing the increased baseline level of the high sensitivity CRP, LDL-C, and LPA predicted risk for 30 years. Covariable adjusted hazard ratio show 1.7 for the high sensitivity CRP, 1.36 for the LDL cholesterol, and 1.3 for the lipoprotein A. And this study again showed 3,066 cardiac events during the 30 years. They found the coronary heart disease and stroke, which appeared to be consistent with those for the primary endpoints of the study. In this study, inflammation, cholesterol lipoproteins shows the increased incidence of the increased incidence with the increased concentration of the LPA, LDA, high reactive CRP, leading to CVD events within the 30 years shown by this slide. So data shows the relationship of LPA to CVD is well characterized in European population, but significant data is lacking in the Asian region population. Overall, levels of the LPA in healthy Asian population are generally lower than in European population. Higher LPA was found in South Asian women than men in all age groups. Although the concentrations and incidence was still lower than reported in European literature. Within Asian population, elevated LPA was universally related to the risk of CAD and is CVD proportional to the increased LPA concentration. The relationship with the stroke was less clear as the studies were limited. A large number of studies were conducted for the risk assessment of the CVD and their outcomes in the Asian countries like China, Japan, India, Korea, Taiwan, Thailand, and Malaysia. But there were no specific separate data for the women in these studies. Only one prospective cohort study in China showed this takes difference in LPA in Asian samples that women had greater median LPA across all age quantiles. Median female LPA was 1.898, higher than the median male LPA level. Overall, median LPA concentration were more in female, 6.7 milligram, than the male, 5.1. Postmenopausal women had higher LPs than the premenopausal counterparts due to LPA modulation because of the sex hormone. The scarcity of the studies in women. This scarcity of the studies in distribution prevalence of the elevated LPA in multi-ethnic and Asian woman population is still unclear. It has suggested that the South Asian might have higher LPA than the other Asian ethnicities. However, there is little to confirm. This is as adequately powered studies have predominantly been conducted only in China, Japan, Korea, and Indian population only. Lacking the data from the Asia Pacific countries, does not suggest actual incidence of women with suffering from the increased LPA and cardiovascular events. So little is understood about the CV implication of the raised LPA and with the inflammation. Despite of the heterogeneity among the studies in Asia Pacific, higher level of LPA in women are found to be associated with the stent restenosis, higher valve involvement, especially aortic valve, 82%, and mitral valve, 37%, and major vessel thoracic aorta involvement also. In a recent study, Wang et al. Found 5% and 3% increase in aortic aneurysm, large artery atherosclerotic stroke, and thoracic aortic vessel calcification in 36% of the patients with increased LPA. That is significant ratio. What are the implications for the clinical practice? So the implication for the clinical practice for long-term studies on this subject is that early intervention and monitoring in women as a routine assessment of women with the screening of the biomarkers. So moving beyond the traditional ASCVD prevention with the extended risk assessment more than 10 years to tailor the personalized prevention strategies based on biomarker profiles. Also on public health initiatives like education, awareness in women for understanding the importance of inflammation and the lipid profiles in CVD. There is need for the early intervention and prevention. So, keeping in view of the outcomes in women with elevated CRP, LPA, up to 70% of the event, there is need for the personalized prevention strategies that go beyond the traditional LDL-C management, as even after reduction in the LDL-C, many women experience ongoing risk due to the elevated inflammation and LPA. Addressing them is the key for reducing the long-term risk, especially due to the hormonal changes and post-menopausal shifts in the lipid and the inflammation profile. So what current guidelines say? Recommendation from the current guidelines for the ASCVD prevention in women typically include lifestyle changes, statin therapy, regular monitoring of BP, and cholesterol level. There are certain gaps in current and traditional guidelines, as there is limited emphasis on the role of LPA and the inflammation and risk assessment, not adequately addressed for the risk in post-menopausal women. Thus, emerging recommendations suggest that inflammatory marker, high sensitivity, CRP and LPA should be acknowledged as an important risk factor in women with family history of cardiovascular disease. Further studies are exploring the targeted therapies aimed at reducing the inflammation as means of the lower LPA level and improve CVD outcomes in women. As up till now, cardiovascular research has been focused more on men than women, often neglecting the unique risk and representation in women and disease progression. So what are the pharmacological approaches for the CV risk management in women? That could be a consideration of the tailoring pharmacological treatment based on the individual risk profile, including cholesterol level, lipoprotein A, and inflammation markers. Currently available lipid-lowering drugs have modest to no impact on the LPA level, whereas in chronic inflammation, those statins which plays a role in residual CVD risk. So the certain statin with the anti-inflammatory effect beyond the cholesterol-lowering drugs should be considered. PCSK9 inhibitors, newer class of the medication that significantly lower LDL level, may be beneficial for the individual with family hypercholesterolemia or those who cannot tolerate the statin. Colchicine, interleukin IB inhibitors have been found CVD risk reduction by targeting inflammation in women with history of ASCVD. Gene silencing approaches targeting the apolipoprotein usually reduce the LPA level will be future strategies for the personalized care. A study which was conducted recently on anti-inflammatory therapy targeting the interleukin IB innate immunity pathway at a dose of 150 mg every 3 months led to a significantly lower rate of recurrent cardiovascular event than the placebo. It was independent of the lipid lowering action. Ongoing research is showing that medicines specifically designed to lower the LPA levels for women with the elevated LPA and family history of CVD may be effective, especially for the postmenopausal women where hormonal therapy HRT may be considered, but it is usually used to manage the menopausal symptoms, but has mixed effect on the cardiovascular health also. Personalized medicine and encourage collaborative decision making between the healthcare provider and patient to optimize the treatment plans will be best strategies here. So my conclusion of the talk will be that experimental clinical evidence from the 30 years studies has shown pathological role and common biological pathways linking the LPA, cholesterol, and inflammation in CVD. Persistent residual CV risk despite optimal management of traditional SCVD risk factors may be attributed to high LPA level and chronic inflammation. Quantification of both LPA and CRP may help estimate residual CV risk. In individuals without known CVD, the presence of pro-inflammatory status as detected by the high CRP level has been found to increase the CVD events associated with the high LPA levels. Thank you so much.
Thank you, Professor Sumbro, for the wonderful talk to let us learn a lot about the inflammation and the risk of CRP, lipoprotein A, and the risk of cardiovascular disease in women. Now we can open to questions from the experts online. There's one questions, one short questions. We have some patients that will check their lipoprotein A and the CRP. Once if the CRP level is high for patients with cardiovascular disease, we will prescribe statin. In addition to statin, we will also prescribe colchicine for these patients. What about your clinical practice for those with higher lipoprotein A level, especially for women with CV disease or myocardial infarctions? We realize that the PCSK inhibitor is effective to lower the lipoprotein A, but it costs a lot of money. So what is your clinical practice for those patients with higher risk with elevation of lipoprotein A?
After this presentation, frankly speaking, I'm just thinking about to start those drugs which beyond the statin therapy, we can help our patients for the control of inflammation, such as you described, colchicine and other drugs. So not yet, we will be conducting studies in our Pakistan, keeping in view of our own traditional and risk factors in our urban and rural areas as well, and the age of the woman, early or postmenopausal age. So it will be future. Future will tell us about the efficacy of these drugs in our population in women. Not yet. We haven't.
Okay, thank you. We still need some more evidence to show that the further treatment effect.
Yes, that's because I have already told that there is no specific study conducted in South Asia countries.
Right.
Thank you.
Is there any question?
Professor, I'd just like to ask if is there any specific patient population that you need to order LPA or HSCRP? So some patients may not seem to have high cardiovascular risk, but in your practice, do you screen these patients?
Yes, well, especially those patients who comes after some form of therapy, interventional or CABG, and they repeatedly come to us with symptoms. In those patients, we have the elevated level of which is CRP and the LPA nowadays.
But what about for patients who don't seem to be at high risk for cardiovascular disease? Is there a benefit for that?
As I have told you that we haven't seen any studies on this subject, so this will be new subject for South Asian countries, and we have to take initiative. Our Asia Pacific has to take society has to take initiative to conduct a study on this subject and the treatment compliance and the results.
Yeah, I think because some patients may not seem to be at high risk, but we don't want to have
What about your
cardiovascular
country?
events.
What about your setup?
Yeah, well, the LPA is something new. It was brought to our attention a few years ago, but we didn't use it that much. But now it's resurfacing, so I think we're going to use it more frequently to catch more patients who are at risk for major adverse cardiovascular events. But for some specific patients who are at low risk, I don't know if, as you've said, there's no studies yet. So I'm personally, I think we need to catch patients more early rather than them having their first major adverse cardiovascular events.
Yeah. So this study from Nepal was published this year in August 2024. Such a recent study, we have to follow the instructions and from this study, and I hope we will conduct a study in South Asian countries also to have effective control of our inflammatory reason for the future cardiac events.
Okay. It seems inflammation is a future target that we can still work on. Okay. If there is then no and further questions, I have to, according to the schedule, I have to transfer the next session to Dr. Relato.
So our next speaker, our next expert is Dr. Nadim Shah from UAE. He's a consultant in interventional cardiology at the Rashid Hospital, Dubai Health Authority at Dubai, UAE. And he's going to give his expert opinion regarding PCI for older adults presenting with acute coronary syndrome. And what did we learn from the ESC 2024? It's an analysis of EARTH-STEMI and Senorita. We're pleased to have you, Doctor.
Good morning, everyone, and thank you, Dr. Relato, for that introduction. Can you see my slides?
Yes.
Okay. So my talk today is on PCI for older adults presenting with ACS. What did we learn from the ESC of this year? And essentially, it's an analysis of the EARTH-STEMI and Senorita trials. I do not have any potential conflicts of interest to disclose. So as a background to my talk, we know that there's underrepresentation of older adults in the traditional PCI trials. Some of the evidence is a little bit conflicting. We also realize that age is an independent risk factor for acute coronary syndromes. And the question is that perhaps PCI can reduce the MACE associated with this ACS. Being an older population, you might expect increased complications if you performed PCI. And the question is whether PCI is safe in older adults. And of course, increasing age is associated with multiple comorbidities that may alter outcomes post-PCI. So we'll delve into these two trials just to see whether it can shed light on some of these queries. So initially, we'll talk about the EARTH-STEMI meta-analysis, which is complete versus culprit-only revascularization in older STEMI patients performed by Gianluca Campo and colleagues. And the research question was to investigate with an individual patient data meta-analysis from RCTs, whether in older patients, those 75 and above who present with STEMI and multivessel disease, whether complete revascularization is superior to a culprit-only strategy at follow-up longer than 1 year. Excuse me. Okay, so their methods where they searched for randomized controlled trials comparing complete versus culprit-only revascularization in MI patients. They had access to the original databases of these randomized controlled trials and the selected STEMI patients aged 75 and above, as I've said, and the original data was extracted and analyzed. The primary endpoint of the study was a composite of death, MI, ischemia-driven revascularization. FFR was performed in approximately 60% of the cases. Safety was a composite of contrast-associated acute kidney injury, stroke, stent thrombosis, and major bleeding. So these were the trials selected. So there was the complete trial, FIRE, full revasc, DYNAMI 3, compare acute, a trial by Hamza et al., and finally the culprit trial. So in total, 7 randomized controlled trials, approximately 20% of the patients from these trials met the inclusion criteria for the age, which had a total of just over 1,700 patients, with 900 in the culprit group and about 800 in the complete group. The median follow-up was 2.5 years, but as you can see, there was heterogeneous follow-up between the trials, so it wasn't. In terms of baseline characteristics, the median age was around 80. As you can see, there was slightly more females in the culprit group. In terms of comorbidities, the groups were well matched in terms of hypertension and diabetes. The culprit arteries were also well matched, with the largest population being the right coronary artery. It was good to see high rates of radial access of around 80% in both groups. In terms of guideline-directed medical therapy, they were also well matched with high rates of aspirin use, P2Y12 inhibitors, ACE inhibitors, and statins. And this was the primary endpoint. So as you can see, at approximately 4 years, there appears to be a benefit for the complete revascularization group with respect to the composite outcome of death, MI, and ischemia-driven revascularization. However, this benefit crosses over at around 5 years, and subsequently the difference is no longer statistically significant. In terms of secondary outcomes, there was no difference in death overall, but understandably, given the elderly cohort, there was an excess of non-cardiac deaths after 4 years in the complete group, but the difference is statistically non-significant. There was, however, less subsequent revascularization in the complete group, which is also understandable given the initial incomplete revascularization in the culprit-only group. The procedure appeared to be safe in this elderly cohort, and as you can see, there was no statistical difference in terms of stroke, stent thrombosis, major bleeding, or acute kidney injury. These were the limitations highlighted by the authors. So in this study, the follow-up was not uniform and there was large variation. Only about 20% of patients had a follow-up exceeding 4 years. The sample size was limited to draw a definitive conclusion regarding death. And being a meta-analysis, unfortunately, data is heterogeneous. and there's usually unknown confounders that may have affected the reported outcomes. So in conclusion, the EARTH-STEMI analysis focused on STEMI patients aged 75 years or older with multivessel disease, and they showed that complete revascularization is, first of all, safe. It reduced ischemic events, but only up to 4 years, which was mainly driven by revascularization. And they were unable to show a benefit in terms of long-term mortality or myocardial infarctions. Okay, so moving on to the next trial, which is the SENIOR-RITA trial, run by the British Heart Foundation, led by Professor Vijay Konadian and colleagues. So they initially highlighted that although there is evidence for the management of elderly non-STEMI patient, the sample size from the trials is relatively small, with less than 1,500. And this is despite the fact that non-STEMI is the most common type of ACS subtype that presents in patients over the age of 75. And in the evidence that already exists, there are a number of limitations, including small sample size, challenges with recruitment, and with no formal assessment of frailty, comorbidities, and cognitive function. So their research question was to investigate whether a conservative strategy with medical therapy alone or an invasive strategy plus medical therapy is beneficial in an all-comer older adults with non-ST elevation MI. This was the study design. So they took 75 and older patients presented with non-STEMI and they randomized one group to invasive arm and another to a conservative arm. They then followed them up for 6 months, 1 year, and then yearly until 5 years, either by telephone or in-person visit. Patients were recruited from various medical units, including emergency departments, medical admission units, cardiology wards, medical wards, geriatric wards at PCI and non-PCI centers. For patients assigned to the conservative arm, coronary angio was allowed if there was a clinical deterioration and it was clinically indicated at the discretion of the treating physicians. And also formal assessment were done on all patients for frailty, cognition, comorbidity, and baseline and follow-up. So the inclusion criteria, as I've said, was age 75 or older, and those presenting with a type 1 non-STEMI during their index hospitalization. Important exclusion criteria included patients presenting with STEMI or unstable angina, those that had cardiogenic shock, patients with a known life expectancy of less than a year, previous randomization in the same trial, or an inability to undergo invasive angio, such as no vascular access site, or an absolute contraindication to coronary revascularization. The primary outcome of the study was time to cardiovascular death or non-fatal MI. Important secondary outcomes included cardiovascular death, non-fatal MI, composite of all death and MI, all-cause death, non-cardiovascular death, recurrent MI, subsequent angio or revascularization, being hospitalized for heart failure, stroke, TIA, and finally, a safety outcome of bleeding, which was defined by the BARC definition. So these were the centers that were included in the trial, and as you can see, they were all from England and Scotland. So they were able to recruit just over 1,500 patients, with 750 in the invasive and a similar number in the conservative arm. The median follow-up is approximately 4 years in both groups, and the analysis was via intention to treat. Of all the screened patients, only about 20% were included in the trial because they had exclusion criteria. 90% in the invasive arm had angiography, and about approximately 6% had it in the conservative group. A very high number of events, almost 100%, were adjudicated by the clinical events committee, and the follow-up was very good, almost 100% of patients across all the time points. The baseline characteristics between the two arms were well matched. As you can see, females were well represented, which is unusual for these trials, with just under 50%. And these were truly elderly, frail patients, as demonstrated by over 70% of the patients being over 80 years of age, with high frailty and comorbidity scores. The groups were also well matched with respect to their risk factors. So about a third had diabetes, about 20% had previous PCI, and about 10% had previous CABG. And surprisingly, about 20% actually had a previous malignancy. The medical therapy was also well matched, with high rates of guideline-directed medical therapy, with high rates of aspirin, P2Y12 inhibitors, ACE inhibitors, beta blockers, and statins. It was good also in this trial to see high rates of radial access. Approximately 50% of those in the invasive arm had revascularization, with the vast majority having PCI. Procedural complications were very low, with low bleeding rates and vascular complications, which I assume is likely due to the choice of radial access for the angiograms. And this was the outcome. So as you can see, there was no difference in the primary outcome of death or non-fatal MI out to 5 years after randomization. If you look at mortality alone, again, there was no difference in the invasive and the conservative arm out to 5 years. However, if you look at just the MIs, there was a significant reduction in subsequent non-fatal MI. So this absolute risk reduction was approximately 3%. That would equate to a number needed to treat of around 30 patients to avoid 1 MI. And in addition, there was a significant reduction in subsequent coronary vascularization. But being an open label design, this was always likely to be the result. With respect to secondary outcomes, the only significant findings were of higher rates of subsequent angiograms in the conservative arm and associated revascularization, which of course is to be expected for reasons that I've already highlighted. In terms of subgroup analysis, the primary outcome findings appeared consistent across all the pre-specified subgroups. These were the study limitations highlighted by the authors. So their sample size was a little bit lower what they had planned, but nevertheless, this is the largest study looking at the specific cohort. The median follow-up was above 4 years. They addressed a important clinical question. They felt that it provided valuable insights into the optimal care of these elderly patients, and it strengthens on the evidence that already existed. However, only 20% of the patients who were screened were recruited into the trial, which was anticipated by the authors, and this just represents some of the challenges to recruit for such trials in this all-comer elderly populations. However, patients who were not randomized had similar demographics to those undergoing randomization, with 55% undergoing invasive and 44% undergoing conservative, and they felt that it strengthened the generalizability of their study findings. And this was the conclusions presented by the authors, that this trial is the largest trial to date in older adults with heart attacks than all previous trials combined. And they felt that it demonstrated that among older adults with a type 1 non-STEMI, an invasive strategy is safe. It did not, however, significantly reduce the combined risk of cardiovascular death or non-fatal MI as compared to a conservative strategy. Treatment with an invasive strategy did, however, reduce the risk of non-fatal MI and subsequent revascularization, and they felt that the results provided a foundation for for older heart attack patients and their clinicians to make an informed decision about whether to undergo invasive or non-invasive management. So what did we learn and what can we apply to our elderly Asian patients? Well, first of all, I think what I took from these two trials is that PCI appears to be safe in an elderly population. And I think that was largely driven by the fact that the majority of patients, or large majority of patients, had radial access. And we do know that radial access, particularly in STEMI patients in the setting of primary PCI, gives us a mortality benefit. And of course, the complication rates are much lower, primarily because of low bleeding and vascular access site complication rates. The main findings of both these trials is that medicines are good for these patients. The PCI for non-STEMI and non-culprit lesions post-primary PCI do not reduce death in the elderly. And the main benefit appears to be reduced MI and subsequent revascularization. Of course, we cannot directly compare both of these trials because one is a meta-analysis and the other is a randomized control study with slightly studying different cohorts and inclusion criteria. Can we apply this data to our patients? Well, most of the data in these two trials is from a non-Asian population. And I don't know about my audience, but what I do find that certainly in the UAE and here in Dubai, we find that our patients actually have more advanced coronary artery disease at a younger age. So the inclusion criteria of 75 and above in these trials, if we had a similar age group, we might actually find more advanced coronary disease in our patients. And that's certainly what I find in our South Asian and Arab populations that I treat on a daily basis. However, I think the data does give us confidence to treat elderly patients conservatively, and it likely already supports what we've already been doing, which is good to see. It gives us confidence that we should take decisions collectively with the patients and their relatives. I feel it gives us confidence to individualize the management of our elderly patients, where we should consider the patient's wishes, the relatives' wishes, their comorbidities, their financial limitations, their frailty, and the comorbidities that they have. And of course, you can always start with the conservative management first and consider PCI later as required. So I'd just like to give you two examples, hypothetical examples of patients, but these might be patients that you see on a daily basis. Certainly we do in our clinical practice here in Rashid Hospital in Dubai. So first of all, you have a 78-year-old lady who presents with an anterior STEMI. You perform successful primary PCI to the LAD. You however, notice residual severe LCX and RCA stenosis, which are both suitable for PCI. The lady is now symptom-free following her primary PCI. She has a background of diabetes and hypertension. She's retired. She's unable to walk very far because of arthritis of her both knees. Her EF has been affected by the anterior STEMI. She has mild renal impairment. Her son mentions to you that she's increasingly forgetful over the last few years. For this patient, I do not feel that complete revascularization will give her a benefit. And this is probably a patient that you'd like to continue with conservative management in the first instance. If, however, the lady beside her, who's also 78, has presented with a non-STEMI, she only takes tablets for hypertension, she's retired but enjoys daily walks with her family. However, over the past week, she has noted that every time she walks, she gets chest pain and has to sit down. Her EF has not been affected by the non-STEMI. She has preserved renal function. And I feel this is a patient you should consider for angiogram, plus or minus revascularization, because I think she would get a benefit from revascularization. With that, I'd like to thank you for your attention, and I'm open to any questions.
Thank you, Dr. Shah, for that comprehensive talk. So we're seeing more of what I got from your talk is that revascularization in older patients is safe, and it's actually should be an individualized approach. And there's so for patients who are not complaining of angina, and medical therapy might be the trick. And if the patients become symptomatic, then revascularization may be considered. I think some of our older patients do not receive optimal medical therapy, probably because of fear of side effects of medications. And also some of our patients who are elderly do not get offered with revascularization because of fear of complications, particularly in the older patients. So do we were patients on the conservative strategy receiving OMT medication, did they not receive actual optimal medical therapy based on the studies, or what do you think?
Well, you raise two important questions. No, both of these trials, as I've shown, they both had high levels of guideline-directed medical therapy. And I think as a result, that's why you didn't find a mortality benefit among the patients. So they all had high rates of aspirin, beta blocker, A statins, etc. You raise an important question about fear of giving elderly patients medications. I think what these studies have shown, that fear is unfounded, first of all, and does make a difference. And secondly, your point about fear of doing angiograms in elderly patients has also been shown not to be true. So you can consider angiogram and revascularization in elderly patients, but what I would highlight is really they have to be done radial. Because often among some interventionalists, there's also a fear of going radial because they feel there's going to be tortuosity, more difficult to do. But that's not what I have found in my daily practice. And I would really encourage people, if it's required, of course, to do an angiogram and to go radial. And I think if you do, and if you choose your patients appropriately, you will get good outcomes.
Yeah. Do you have any more questions from the?
Thank you for Dr. Shai's experiencing and educational talk. I have a question. Do you think for elderly patients, we still need to arrange stress test after the first invasive intervention for these patients, or such as a CT FFR for those patients when we for our decision for the next intervention?
Well, if you go by these studies, in the senior RITA, I didn't come across any evidence of CT-FFR or FFR in general. The meta-analysis did found around 60% of patients had FFR, but there was no CT-FFR. But yeah, I guess so. If it's a person that you feel you want to take for an angiogram, but there are some concerns about going by the invasive approach, then certainly I think CT-FFR will play a role. But I do not feel traditional exercise, stress tests, etc., would have a role in these patients, and I think we shouldn't do those anymore.
Do you have any more questions and comments?
As patient is taking aspirin, clopidogrel, and in elderly group, you see, if we are maximizing the drugs in elderly group, whether he will be, what will be the compliance level of the patient? We should think about that, you see. Well, and at the cath lab interventional cardiologist level, FFR is most powerful strategy to perform and see whether the patient needs angioplasty or not. Yes, sir?
I didn't hear the first part of your question, Professor, but an answer to your second part, yes. So certainly post primary PCI, if you have other lesions which you do not feel may be severe or indeterminate, we routinely would do FFR for those lesions to see whether they would require or not. And I think that's a good strategy to pursue.
because the education level of the patients also matters. Frequent visit of the hospitals nearby the health centers, as well as the time given by the healthcare provider is also a matter over here. We have to think a lot of the things in decision of taking whether we should perform angioplasty in such patients, and they should not perform angioplasty in our setup.
Absolutely. I fully agree. We face those challenges here also. So we are constantly trying to educate patients about compliance. Some of our patients have financial difficulties, even not just for the angiogram, for the medicines themselves. So we are always trying to help our patients, first of all, have an understanding, and secondly, educating them how to get access to those medications where it's not too much of a burden on their finances.
Thank you, Doctor. If there are any no more questions,
No other questions, shall I disconnect?
maybe we can proceed to the next part.
Okay, we can proceed to the next one. So let me introduce the next speaker, Dr. Riletto. He's a active consultant, cardiology and intervention cardiologist in the St. Luke's Medical Centers, one of the global city VRP Medical Center. And he's also the visiting consultant, interventional cardiology, the Medical City, Manila, Philippines. The topic he's going to talk today is about beta blocker interruption or not after uncomplicated myocardial infarction, also the Asian Pacific point of view. Welcome, Dr. Riletto.
Thank you, Doctor. I'll just share my screen. Can you see my slides? So I'd like to thank the organizing committee for having me today and talk about this topic, which is one of the late breaking trials in the ESC and one of the more controversial ones. So I'll be discussing about beta blocker interruption or not after an uncomplicated myocardial infarction, the ABYS trial, Asian Pacific point of view. I have nothing to disclose for this particular talk. So the appropriate duration of treatment with beta blocker after an acute myocardial infarction is unknown. So in the past, there has been no large RCTs and no recommendation on the duration of beta blocker therapy after an MI. And many of our patients are on lifelong beta blocker therapy. And actually, data are needed on the safety and efficacy of interruption of long-term beta blocker treatment to reduce side effects and improve quality of life in patients with a history of uncomplicated myocardial infarction. The ABYS trial, which was published August this year, is an open-label non-inferiority trial conducted in France, which randomly assigned patients with a history of myocardial infarction to interruption versus continuation of beta blocker. Well, we know that beta blocker has been the standard of care for MI, and in fact, it has been established as a quality measurement tool after hospital discharge in patients suffering from an acute myocardial infarction. However, the benefit of beta blocker therapy in patients with myocardial infarction is derived from trials carried out before the advent of modern myocardial reperfusion and pharmacotherapy like antithrombotics, statins, renin-angiotensin aldosterone system blockers. Early reperfusion strategies also led to a drastic reduction in the risks of heart failure and death post-MI, brought about by reduction of infarct size. Beta blockers do have some adverse effects which may impact quality of life. And some of the most common observed adverse effects are excessive tiredness, dizziness, especially in the older patients, insomnia, impotence, hypoglycemia, etc. And current large strategies and observational studies did not provide sufficient evidence to support long-term beta blocker in patients with uncomplicated MI. And given the lack of evidence, long-term beta blocker therapy has been debated considering side effects, drug interactions, adherence issues, and the potential for added healthcare costs. So this has put into question, actually, the necessity of adding or continuing beta blocker in patients with preserved ejection fraction and no other indication for beta blockers. Previous guidelines gave beta blocker therapy a class 1 recommendation for acute coronary syndrome for the first year of treatment and was extended up to 3 years, actually without convincing data. And the clinical benefit of beta blocker after ACS in patients with reduced ejection fraction is supported by evidence from recent trials. However, evidence for beta blockers for patients who had an acute uncomplicated MI and those who have LVEF of more than 40% has not been established. In fact, in the 2017 ESC-STEMI guidelines, routine oral beta blockers in post-MI patients have been downgraded, has been given a downgraded recommendation to class 2A with a level of evidence B. So in a recent trial published this year, the REDUCE-AMI trial, more than 5,000 patients with acute MI who underwent early angiography who had an LV ejection fraction of more than 50% were assigned to beta blocker treatment or no beta blocker treatment. And the primary endpoint was a composite of death from any cause or new myocardial infarction. And at a median of about 3.5 years, there was no significant difference between the two groups with a p-value of 0.64. Safety endpoints were also similar between the two groups. The conclusion was, among patients with acute MI and preserved ejection fraction, long-term beta blocker treatment did not reduce the risk of hard endpoints like death and myocardial infarction. There were, of course, some limitations to this study, namely the trial was open label, and there was crossover of 14% to the beta blocker group after 1 year follow-up. The ABYS trial was a similar trial. However, instead of testing the hypothesis of whether it is beneficial to start beta blocker in uncomplicated MI, as in the REDUCE-AMI trial, ABYS trial tested the hypothesis of the benefit and safety of withdrawing beta blockers in uncomplicated myocardial infarction. So the ABYS trial is a prospective, multi-center, open-label, non-inferiority trial that was conducted at 14 clinical sites in France. Those included in the trial were patients who had a prior acute myocardial infarction, 6 months or more before randomization, and who are on beta blocker of any type or dose. Excluded from the trial are those who have chronic heart failure, patients with LV ejection fraction of less than 40%, and any cardiac events within 6 months before enrollment, and other indications for beta blockers such as uncontrolled hypertension, arrhythmia, etc. Patients were randomly assigned to in a 1:1 ratio to either interruption or continuation of beta blocker therapy with the same agent at the same dose. And the primary objective is to demonstrate non-inferiority of the interruption of beta blocker therapy on major adverse cardiovascular events, which includes all-cause death, stroke, myocardial infarction, and hospitalization for any cardiovascular reason, which is after an uncomplicated MI, compared to the continuation of beta blockers. And the main secondary objective is to evaluate if there is a significant difference of interruption of beta blocker on the quality of life compared to continuation of beta blocker. So if we look at the baseline characteristics, about 2/3 were ST elevation myocardial infarction, and 1/3 were non-ST elevation MI. And these were similar between the two groups. The median time from index myocardial infarction to randomization is about 2.8 to 2.9 years. So these patients were practically out of the acute phase already and were considered stable. About 95% of patients in both groups actually underwent revascularization, mostly in the form of percutaneous coronary intervention. And more than 90% in both groups had complete revascularization, and only a small percentage actually underwent fibrinolysis. What were the results of the trial? So the composite endpoint of death, myocardial infarction, and hospitalization for cardiovascular reason occurred in 23.8% in the interruption group versus 21.1% in the continuation group. The pre-specified margin for non-inferiority of the beta blocker interruption was not met with a p-value of 0.44 and a hazard ratio of 1.16. The result was not deemed statistically significant, but numerically speaking, more primary endpoints actually occurred in the interruption group. For hard endpoints like death, MI, stroke, the results were very similar between the two groups. In terms of death, 4.1% occurred in the interruption group and 4% in the continuation group. For myocardial infarction, events were 2.5% in the interruption group and 2.4% in the continuation group. And for stroke, events were 1% for both groups. Here's where the difference comes in. So the results were significantly affected by hospitalization for cardiovascular reasons, which actually skewed the results in favor of continuation of beta blocker, with events in about 18.9% in the interruption group and 16.6% in the continuation group. The most common reason for hospitalization was coronary related, which occurred in 14.2% in the interruption group and 11.9% in the interruption group, which were primarily driven by angina and leading to angiography and coronary intervention. Other reasons include tachycardia and also heart failure, although there seems to be no significant difference between the two groups. For the secondary endpoint, interruption of beta blockers did not appear to improve quality of life, with just 0.05 point difference between the two groups. So the ABYS trial hoped to prove the hypothesis that the interruption of beta blocker would be non-inferior to the continuation of beta blocker over a 3-year follow-up among patients with a history of uncomplicated myocardial infarction. However, the non-inferiority of this strategy was not shown with respect to the risk of death, non-fatal MI, non-fatal stroke, or hospitalization for cardiovascular reasons. Also, interruption of beta blocker did not result in an improvement in the patient-reported quality of life. Interruption of beta blocker actually led to a numerical increase in hospitalization related to angina, leading to coronary-related procedures. So, a patient now comes to my clinic doing fine maybe 2 years after STEMI and underwent successful coronary revascularization and is doing really good. No angina, no heart failure symptoms, 2D echo is normal with ejection fraction of 55%. So the question is, should I continue his beta blocker? To discontinue his beta blocker to lessen his medications, knowing that he's been stable? Well, based on the ABYS trial, I can probably discontinue his beta blocker, and I know that it would not significantly impact his risk for future events like death, MI, and stroke. However, the risk of having recurrent angina leading to hospitalization and potentially coronary interventions may dissuade me from stopping beta blockers just for the sake of reducing pill burden, particularly if the patient does not ask for its discontinuation. In certain countries where healthcare expense is out of pocket, recurrence of angina leading to hospitalization and coronary intervention may push a clinician to just continue beta blocker instead of having to deal with these unexpected costs. The results of the study may also have potential bias since the decision for hospitalization is based on the judgment of the clinician. Also, it is important to note that this trial involved more than 95% revascularization. This is not applicable to patients who are only medically. This may not be applicable to patients who are only medically treated. And it is too early to conclude whether interruption of beta blockers will really benefit patients with uncomplicated MI. And more randomized controlled trials are needed, and several of them are already ongoing, like the Reduce with Heart, DONBLOCK, and Reboot. Thank you.
And thanks, Dr. Relato, for the educational talk about the discontinuation of beta blockers and the ABYS trial and some other informations. Is there any question from the audience and from the experts online? For the discontinuation of the beta blocker, do you think the types of the beta blocker is a consideration for these patients? For example, the previous non-selective beta blockers and the newest selective ones, are they all the same for the patients, or will have any other considerations among the beta blockers?
That's an interesting question. This study did not, obviously that's a limitation of this study because whether it did not screen patients who had beta blockers that were previously used in the trials for MI. So all beta blockers were actually included in the study. And whether that affected the results, we do not actually know.
There was some interesting discussion that for patients with mild reduced ejection fractions, they may keep the beta blocker to be benefit for them. And for those with preserved ejection fraction after myocardial infarctions, you may discontinuation the beta blocker. What do you think about this opinion? Is there any analysis from this study regarding the ejection fraction or regional wall motion of the myocardium?
Most of the patients included were in the study had an ejection fraction of 60%. And about only a quarter of the patients included those who had an ejection fraction between 40 to 50%. I don't think they did a subgroup analysis on those patients, and I think that's interesting to look at.
There's still one question from the audience. Professor Lin is asking, what is the proper time to stop beta blocker? 1 month, 3 months after the ASCVD, or any other anticipation?
So in this study, they followed up patients, so at least a year after the ACS. So maybe they can discontinue after 1 year. So actually the definition was the contention was actually that acute MI only, there's a benefit only after within 30 days after the event, and it's probably safe to discontinue after a year. So that was the hypothesis. But we need more RCTs regarding this.
What about those patients who are having non-culprit arteries as well? You have put a stent in the compromised artery or infected artery, but he or she has other arteries, blocked arteries also. So what will be the strategy in future? Because if he is in working condition.
Personally, I would still recommend for these types of patients who are not completely vascularized to just continue beta blocker therapy, because actually what we've seen in this study is the risk of rehospitalization after we discontinue the beta blocker. And the primary reason for that was due to recurrent angina. And this actually led to hospitalization and subsequent coronary angiography and coronary interventions. So for those patients, I think it's better to continue beta blockers rather than discontinuing. So it's important to note that in this trial, more than 95% of patients actually had complete revascularization. Oh, sorry, about 90%.
All right. If there is no any,
I was asking about those obstructed arteries apart from the coronary artery which was stented, and how can he continue with his routine work with time consuming on the walking and going their offices, raising that can raise their heart rate as well.
Yes, for those patients, it might be prudent.
This is a practical question. I know, practical question. We have to think about it.
Yeah. So for those patients, I think it's just prudent to continue the beta blockers.
Okay, thank you.
Yeah, I think we can move to the next session.
So our next speaker would be Dr. Cho Kai-Wu from Taiwan. He's a professor at the Department of Internal Medicine, National Taiwan University, National Taiwan University Hospital, Taipei, Taiwan. So he'd be talking about GLP-1 receptor agonist and finerenone. Is it effective in HFmrEF and HFpEF? So he'll be talking about the flow and the fine arts heart failure, not only in obesity and HFpEF. So we're pleased to have you, Dr. Cho Kai.
Thank you, Dr. Rilato, for the introduction, for the kind introduce. So the next session, I will be talking about the effect of GLP-1 receptor agonist and the finerenone effective in HFmrEF and HFpEF, especially focused on flow and fine arts heart failure. And I will analysis according to a meta-analysis about the obesity heart failure phenotype with the effect of GLP-1 agonist and also the fine arts study. We also realize that heart failure can be divided into several subtypes. And for patients with HFpEF, they generally have elderly age and are female predominant and have a lot of comorbidity comparing to those of HFrEF. And for the medicines suggested before, only SGLT2 inhibitor could be the class 1 choice for the treatment of HFpEF. And for ARB and MRA, they are all class 2B indication according to current guidelines. So need further studies to clarify which is important or effective in the treatment of HFmrEF and HFpEF. And according to the diabetes guideline for the treatment that can reduce heart failure risk, GLP-1 and agonists like lixisenatide, liraglutide, or semaglutide, they have all some small studies regarding the treatment of HFrEF. And they are all 2B suggestion for the treatment for DM with heart failure. And what about previous effects for GLP-1 agonists on heart failure? There were several small studies regarding the GLP-1 treatment for heart failure. For example, the liraglutide FIGHT study comparing liraglutide and the placebo. You can see here the GLP-1 over heart failure had no clinical effect for the death or heart failure rehospitalization. And they could not increase ejection fraction either, comparing to the treatment of placebo, even for those with heart failure. And there were also some small trials to compare patients with heart failure, especially the HFrEF. And the conclusion is that using of GLP-1 agonist has at best only a modest effect on ejection fraction improvement according to some small number studies. The limited number of subjects in each trial and the variation in dosage and duration of therapy among the trials somewhat limit those conclusions. And all these small RCTs include HFrEF patients with reduced ejection fractions. So there are no definite studies for patients with HFpEF until the recent data from the STEP-HFpEF and some recent studies we are going to talk about. So comparing to the previous GLP-1 agonist, we realize that the treatment of GLP-1 for heart failure are at least with safety, with believable safety for those patients. And in a recent meta-analysis in patients with type 2 DM, GLP-1 agonist was significantly associated with the risk of heart failure hospitalizations. And most of the studies did not differentiate between HFpEF and HFrEF. There are some potential for benefit with GLP-1 agonist for HFpEF. For example, according to the mechanism of a GLP-1 agonist, they can actually effective for the patients with obesity. They can decrease the body weight, and they are able to benefit for the glucose control, and they can decrease blood pressure to some extent. And they are also benefit for CKD. And they can inhibit inflammation, which is also a mechanism for the development of HFpEF. And according to the subsequent mechanism, they can inhibit cGMP expression, and they can increase the inhibition of fibrosis. So we take as a recent published meta-analysis in ESC that the background is that we all realize the STEP-HFpEF program, once weekly semaglutide with 2.4 milligram per week, improved HFpEF improved heart failure-related symptoms and the physical limitations, and it could also reduce body weight in participants with obesity-related HFpEF. So whether semaglutide also reduces clinical heart failure events in these groups remains unresolved. So in a recent meta-analysis, they enrolled patients from the SELECT trial and also from the FLOW trials. We realized that the SELECT trial included patients with obesity and with a BMI for over than 27 and with cardiovascular risks. And in the FLOW trial, they enrolled the patients with chronic CKD with chronic kidney disease, and they check up the kidney outcomes. And both studies from the SELECT and from the FLOW trials were with positive effect. That semaglutide could be beneficial for the death outcome and for the heart failure outcomes in these patients, both for the patients with higher cardiovascular risks and those with CKD. So this meta-analysis enrolled patients from STEP HFpEF and state HFpEF diabetes, and also from SELECT and FLOW. They enroll patients with well-phenotyped obesity-related HFpEF in STEP heart failure, and also in STEP HFpEF DM. And in participants with the SELECT and the FLOW trial, they enrolled patients with subtype of HFpEF, HFrEF, and unknown type of heart failure. So there were about 2,000 patients from the participants from SELECT and FLOW trials, and there's only 300 patients from the FLOW trials. The main endpoint for the meta-analysis was a composite of cardiovascular death or worsening heart failure events, including hospitalization or urgent visit due to heart failure. And heart failure events adjudicated in SELECT STEP HFpEF and STEP HFpEF DN investigator reported in FLOW. The additional endpoints, including worsening heart failure events alone and the CV deaths alone, were also reported. And the safety endpoints included any side effect leading to permanent treatment discontinuation. And you can see that overall, around 3,700 patients were enrolled in this meta-analysis. Their patients were about 64 in age, and they were male predominant. And with most of them are with ejection fraction for more than 40, and with 84 of them are within the diagnosis of HFpEF. And most of them are with obesity with a BMI weight for over than 27, and with about 80% of the participants are with BMI for more than 80%, for more than 30. And most of them are with use of diuretics, and 80% of the patients took beta blocker. Interestingly, only 7% of the patients took SGLT2 inhibitors in this meta-analysis. So these were the results. You can see here that semaglutide was actually benefit for CV deaths and heart failure events in this meta-analysis, for a decrease of 30% of the primary endpoints. And semaglutide was also effective for first heart failure event and also a borderline effect for CV deaths. You took the sub-analysis for overall, the most benefits came from the STEP HFpEF and came from the STEP HFpEF DM. And the most the reduction of heart failure events also from STEP HFpEF and STEP HFpEF DM. With this sub-analysis, you can see here the interactions between body weight are actually important. For patients with BMI more than 35, they were actually more benefit for the treatment of HFpEF. They can get a decrease for more than 50% for the primary endpoint, which in turns, on the contrary, patients with BMI less than 35, they did not have a benefit for the treatment of semaglutide. And there was no significant serious infection or cardiac disorder comparing semaglutide to the placebo. And there were several limitations for this meta-analysis. The degree of heart failure phenotyping different across the trials, and the event rates were actually lower than in recent HFpEF trials. And the dosages of semaglutide were also different in FLOW and in other trials. And the duration for treatment were also different across the trials. And most patients have overweight or obesity in these trials. And there was few non-white participants, which limited the generalizability of the results of the study. But from these trials, we can summarize that the treatment of semaglutide was actually effective in those with overweight. But we cannot say that for patients with non-obesity phenotype of HFpEF could benefit from the treatment of semaglutide. There was a newest published summit trials using tirzepatide. We realized that this trial could be published in HA, could be announced in HA this year. They also included patients with BMI for over than 30. You can see here that patients with heart failure symptoms, and most of them are with HFpEF. The preliminary data just shows that the treatment of tirzepatide was also effective to get a decrease of 38% for the primary endpoint. It is interesting that we can see the further effectiveness comparing to the effective of tirzepatide in a subgroup of this study. We will hopefully we can see that the treatment for patients with less overweight also get a benefit for the treatment of tirzepatide. And now we turn to the Kerendia and the treatment of newest finerenone. Finerenone is actually a non-steroidal MRA blockage. It could be a receptor for the MR agonist, different from previous steroidal MRA. Because of the different downstream effect of MR activations, with the blockage of the non-steroidal MR receptor, the Kerendia could decrease urine albumin ratio for more than 32%, which is different from the previous steroidal MR agonist. And its preliminary data, its previous data was focused on DKD and the finerenone. You can see here from the Figario and the Fidelio DKD studies, they included DM patients with proteinuria. And we can say these patients were more advanced CKD with diabetes. For these DKD patients, they compare the effectiveness of finerenone and with placebo. And from the analysis of the Fidelity, which included patients from Fidelio and the Figaro DKD trials, for more than 13,000 of DKD patients, they actually got a benefit for a reduced risk of severe morbidity and mortality for 14%, and a reduced risk for first heart failure hospitalizations. And I think most of the results, most of the benefits just came from the reduced risk of CKD progression. And they also got a response of a reduction in UACR respective of SGLT2 inhibitor use at baseline. So the ADA and the CADIGO consensus just positioned the finerenone after RAS blockade and SGLT2 inhibitor to against persistent cardiorenal risk for those DKD patients. So in the recent data from the FINHEART trial, the investigators just want to see if this medicine was also benefit for HFmrEF and HFpEF. So the FINHEART heart failure evaluated the efficacy and the safety of finerenone in patients with heart failure with ejection fractions more than 40. Under traditional or just the treatment according to GDMT, the investigator just compared the use of finerenone with a maximum dose of 40 milligrams per day according to their eGFR and with matching placebo. The primary endpoint would be number of cardiovascular events and total heart failure events. And the secondary endpoints would be heart failure events and also the KCCQ life score. and with whether there is an improvement in NYHA function class. The inclusion criteria included those with age 40 years old and with heart failure diagnosis, with ejection fractions more than 40, and with diuretics use prior to randomization. You can see here that the FINHEART heart failure patients, most patients was largely consistent with other contemporary heart failure trials, but patients had more acute heart failure, which was different from previous SGLT2 inhibitor trials. And the use of the loop diuretics was among 70% of the patients in the trials. And there was also only 13% patients had used SGLT2 inhibitors. And the primary result was positive for the reductions in the composite of cardiovascular deaths and the total heart failure events after the prescription of finerenone. And you can see the sub-analysis that the composite CV outcome was positive. Most of the outcomes components was a benefit for the finerenone over heart failure events. And this was the benefits for the pre-specified subgroups. For patients with heart failure, different classes, and with different blood pressure, and with different NT-proBNP levels, finerenone also showed a benefit effect of comparing to the placebo. And for those without obesity, phenotype, the interactions was negative. That means finerenone was benefit for patients with overweight or with those with non-obesity phenotype HFpEF. And there was no difference for age, sex, and the ratio. You can see here that ejection fractions actually had no interactions during this analysis. So we can say that finerenone was generally benefit for patients with HFpEF and HFmrEF, regardless of the ejection fractions, according to the p value of this analysis. 90% of patients enrolled in FINHEART and had overlapping CKM conditions. They had various characteristics of the development of heart failure. So generally, finerenone was effective for heart failure with CKD and for heart failure with diabetes. So finerenone was associated with significantly improved kidney outcomes comparing to placebo in the FINHEART program. So patients had less cardiovascular deaths, and most of the benefits just came from heart failure hospitalizations and CV deaths or heart failure deaths. So these were the conclusions. Finerenone is the first and the only MRA to demonstrate definite cardiovascular benefits in a broad population of patients with heart failure and the LV ejection fractions for more than 40. The effects of finerenone on the CV composite outcome were consistent across a broad population, regardless of baseline use of an SGLT2 inhibitor or the LV ejection fraction status. Finerenone demonstrated significant benefits in the secondary efficacy endpoints of total heart failure events and the patient-reported health status. And this medicine was generally well tolerated, confirming the well-known safety profile with a comparable incidence of treatment emergent side effect to placebo. So thank you for your attentions for my the present of the previous trials published in ESC.
Thank you, Dr. Wu. Do we have any questions or comments from the panelists online? So it's really exciting. Actually, we're seeing used to be we're not we're only limited with medications when it comes to HFpEF, but right now we're seeing medications really who need robust evidence that benefit these patients. Yeah, doctor. So my question to Dr. Wu, so this trial, this included patients who are the flow trial. It included patients who are obese. So did semaglutide have an independent direct effect on the primary outcomes, or is it it could be could have it affected the outcomes due to weight loss, or is it an independent effect?
Yeah, that's one of the most important questions that we all ask about the studies. According to the analysis for body weight, actually body weight is a significant factor for the effect of semaglutide. If you just divided the patients with body mass index for over than 35, semaglutide had a significant effect for the primary endpoints. But for patients with body mass index less than 35, actually the semaglutide had no significant effect for the primary endpoint. That means most of the effect for semaglutide still through the reduction of body weight. So we still did not see effect for those GLP-1 over patients with non-obesity phenotype of HFpEF currently.
Do we have more questions? So I think if there are no more questions or comments, we can now proceed to the next topic.
Okay. I'm sorry. I think there's one question from Professor Sumro.
Yes, Professor.
What does
What's the question? How does finerenone's mineralocorticoid receptor antagonism impact HFpEF differently? I think this is from
other
HFrEF or HFrEF.
or other MRA? Then HFrEF.
Professor, are you asking about HFpEF versus HFrEF?
I think for the finerenone is generally a different kind of MRA. It's a non-steroidal MRA. So according to its mechanism, the subsequent signal transduction for finerenone included the inhibitions of including downregulation for the effect of cGMP. So it could actually decrease the inflammation, and it could also decrease the amount of fibrosis. So it's generally is more benefit comparing to other MRA like spironolactone or Inspira for the effect of HFpEF. So that's one explanation for its effect against the kidney functions and against the HFpEF development. So for HFrEF and HFpEF is different. For HFrEF, MRA is generally the class 1 indication. So I think for HFrEF, the MRA is always suggested, no matter it's spironolactone or finerenone. But for HFpEF, only finerenone has a benefit because of the downstream regulations for cGMP or other inflammation pathways. And there is another questions regarding how to choose between SGLT2 inhibitor and the GLP-1RA. Both are expensive drugs. For patients with heart failure, generally SGLT2 inhibitors are the only class 1 heart failure management medicine. So for patients with heart failure, no matter they are HFpEF or HFrEF, it's reasonable to prescribe SGLT2 inhibitor. But for GLP-1 antagonist, we only see its effect for patients with obesity phenotype HFpEF. So I think for patients with heart failure, we should prescribe SGLT2 inhibitor once the diagnosis is documented. And for those with specifically overweight or body weight for over than and BMI for over than 30, we can think about the prescription of GLP-1 antagonist. Okay, so maybe we can move on to the next session. Oh, it's my great pleasure to introduce Dr. Min Mook from Thailand. Dr. Min Mook is a clinical interest instructor from the Division of Cardiology, Department of Medicine of the Ramasibadi Hospital and the Mahidol University from Bangkok, Thailand. His topic today is about mitral clip or tear effective in HFrEF with significant functional MR. Also an Asian Pacific point of view. Dr. Min Mook, please.
Thank you so much, Dr. Wu, for your high introduction. Let's see my slide, please. Can you see my slide?
Oh, no, not yet.
Not yet?
No. Yeah.
Yes.
Okay. Okay, thank you so much for your kind introduction. My today topic is the MTR for the heart failure reduced EF patient with significant functional MR. This study called ReShape-HF2 that's what presented and published simultaneously during the ESC. This is my disclosure slide. For everyone who unfamiliar with the mitral clip, this is the surgical replication technique from the Alfeli stitch that was introduced by Dr. Alfeli from Milan a few years ago. This is the less invasive device that performed from femoral vein to the heart. The clip was approximate the anterior and posterior leaflet together to reduce the MR. For the patient with a functional mitral regurgitation, there were two studies before in the past, that's COAPT trial and mitral FR. For the COAPT study that was presented in 2018, they studied the patient with heart failure reduced EF with functional mitral regurgitation that has the refractory symptom after the GDMT. They enroll 1-to-1 between the mitral clip plus GDMT with GDMT and GDMT alone. At the 2-year follow-up, you can see from the graph on the right panel, the primary endpoint was heart failure hospitalization. As 2-year follow-up, you can see in the device group has a lower rate of heart failure hospitalization by 47% compared to the patient who just used the GDMT alone. In 2022, the heart failure guideline from the ACC and HA, they recommend to use the MTR for the patient with secondary MR with ejection fraction less than 50% with a persistent symptom after GDMT and mitral anatomy variable. That means the ejection fraction 20 to 50%, LVESD less than 7 centimeters, and also the PSP less than 70 millimeter mercury. But there are some gap of evidence because in the COAPT trial, they only use the mitral clip first generation that only have one size. But now we are in the era of the G4, generation 4 of the mitral clip, that now we have 4 sizes of the clip. And if you look at the result from the expand G4 registry, you can see the at 1-year follow-up, the MR less than or equal 1 plus up to 92%. That's very high as 1-year follow-up compared to the first generation that was like a 60%. But now we can achieve the MR reaction about 1 plus in almost 93%. And also medication from the COAPT trial, that's the GDMT was 90% of the beta blockers. The last blockage is only 2/3 of the patient, and MIA just about half of the patient. At that time, the SGLT2 inhibitor was not indicated in those patients, so they don't report the use of the SGLT2 inhibitor in that trial. But if you look at the recent data, if we put on model GDMT, combination of ARNI, beta blocker, MIA, and SGLT2 inhibitor, you can see the event-free survival is better than the old GDMT, that means HR plus beta blocker. And also at COAF trial, they enroll the patient with the MR 3+ or 4+ only. But how about the 2+ MR? Because we know the even 2+ MR in patient with ejection fraction less than 40%, that's increase the risk of the MACE event. And also the nature of the FMR is dynamic. Sometimes the patient come to us 2+ MR, but at home sometimes 3+ or 4+, and the patient would have the adverse event, even 2+ MR. For this trial, the ReShape-HF2 trial that's presented in the ESC this year. This mainly study from the Germany. This is it took like 9 years to complete this study from March 2015 until the April 2022. They study the patient with a functional MR, ejection fraction about 20 to 50%, and NYHA class 2 to 4 with the functional MR 3+ to 4+. And also the patient would have the heart failure hospitalization within a year before enrollment, or increase the NT-proBNP or BNP level. They enroll the patient randomly, one to one fashion between the mitral clip plus GDMT or GDMT alone. They follow up the patient up to 24 months, and also for the first patient they follow up longer, the up to 8-year follow up, the average follow up time about 3.5 years. The primary endpoint including the recurrent event of CV death and heart failure hospitalization at 24 months, and also the recurrent event of heart failure hospitalization up to 24 months, and also the improvement of the KCCQ at 1 year follow-up. This study is when compared to previous trial, that means COAF and mitral-FR, the age is almost similar, about 70 years old, and GFR is a CKD class 3. But if you look at the mean EROA, the ReShape-HF2 trial, they enroll the patient in the smaller EROA, about the mean about the 0.23 compared to the 0.4 in the COAF trial, and 0.31 in the mitral-FR. That means they enroll less severity of the MR. This is the new population, we call the third population of the patient. And also the heart failure medication, because the trial took like a 9-year study. So about 1/3 of the patient, the SGLT2 were indicated. So this trial, that means we compare the newer generation device that we use the G2, G3, and G4 mitral clip with the modern GDMT. That means a 4 pillar of heart failure, combination of the ARNI, beta blocker, MIA, and SGLT2 inhibitors. When we look at the medication at the baseline, you can see the beta blocker in the ReShape-HF2 high as a 96%, and also the last bucket up to 82%, and also MRA and SGLT2 inhibitor, that's more than the COAF trial. That means we can compare with the real world evidence, because when you look at the COAF, sometimes the we said that the not appropriate the GMT, but now the reshape SF2, we use the contemporary GDMT. The primary endpoint is heart failure hospitalization and or CV days. You can see in the device arm, the primary endpoint was reduced by 36% in the heart failure hospitalization or cardiovascular death. If you look at the co-primary endpoint, that means the heart failure hospitalization, you can see the heart failure hospitalization reduced by 41% at 2-year follow-up. And also the quality of life, when we measure the KCCQ change from the baseline, you can see in the device arm, the change of KCCQ is about 19 compared to the 8 in the control group. This is significant. When we look at the secondary endpoint, the MR reaction, 6-minute walk test, and also NYS change is better in the device group compared to the medical GDMT only. This is summary, the primary endpoint reduction by 36% for the heart failure hospitalization or cardiovascular death, 41% for the recurrent heart failure hospitalization, and also improved 11 points in the KCCQ quality of life score. This is a summary from the presenter. In the patient with the less severe functional mitral regurgitation, that means moderate to severe, who received the GDMT, the addition of the MTR using the meta clip can lower the rate of the first and recurrent hospitalization for the heart failure or cardiovascular death. And also, this might brought the application of the MTR for the patient with the less severe of the mitral regurgitation. For the Asia Pacific perspective, when we compare to the largest registry from Japan, that's called Ocean Mitral Registry. This is the immediate outcome. When we look at the patient with the secondary MR, you can see at the 1-month follow-up in the Ocean Mitral Registry, you can see the MR reduction from the 3 to 4 plus to the less than 2 plus is around 96%. That's very high. And also the improvement of the functional capacity to NYSA class 1 or 2, about 94% at 1 year. They follow up the patient longer to the 1-year follow-up. You can see the all-cause death in the primary, in the secondary MR was 12.6% compared to the German registry of mortality about 20%, and the US registry is about 25.8% at 1 year. That's much lower in Asian, that's we call the Japan registry. This is not surprising because if you look at the data in the cardiovascular outcome in the patient with heart failure relief EF, the Japan has the lowest endpoint, like a cardiovascular death or cause death. But if you look at other regions like Thailand, Philippines, Taiwan, is higher than in Western and European. And also, if you look at the previous guideline, the patient with the severe secondary MR with ejection fraction less than 30%, who remains symptomatic despite GDMT, they say that MTR just to be indication after careful evaluation for the ventricular assisted device or transplantation. But if you look at the data in Asia, we have the 62% of the world population, but the distribution of heart transplantation is only 5.7% in Asia compared to the other region like US is more than half what performed in US. I just want to finish my talk with the case presentation. This is the case of the functional MR, the patient with the 53 years old gentleman. He had admitted many times, years, and this time he was admitted to our hospital because of worsening heart failure, NYSA class 4, and he has multiple comorbidity like a hypertension, diabetes, chronic HBV infection, AFib, and also the non-ischemic cardiomyopathy requiring the CRTD implantation few years ago. He was put on optimized GNP, including the sacubitril Z-hand, beta blocker MIA, and tolvaptan. This time he has a cardiogenic shock and he was admitted to CCU. We put a SWOT in. You can see the hemodynamic parameter. The cardiac output sometimes is low, index about 1.9 only. So after the heart team transplant meeting, he was put on the heart transplant list. This is the echocardiogram. You can see the moderate to severe functional mitral regurgitation, ELA about 0.25. When we wait for heart transplantation, because we don't know how long should we wait, because the waiting list is quite long in Thailand. So we decide with the heart team to do the pancreatic edge-to-edge repair using the metacrypt as a bridging treatment. So this is the result after 2 clips. Is take like a less than 1 hour procedure. You can see the MR reduction now just mild. This is the beautiful of the procedure. You can see the patient. This is the 2 hours after the procedure. He laying down on the bed, but he can read the book. Normally we don't put any line, but this patient is cardiogenic shock. We still have the swan, but normally the patient we just remove everything at the cath lab and no need to stay in the ICU. And most of the patient can be discharged a day after the procedure. And fortunately, after the procedure, the patient improved quite well, and it can be delisted from the transplant list and follow up for 5 years without any heart failure hospitalization. If we illustrate this case into the case report, if you want to look in more detail, you can look at this article. So this is my conclusion for the M-tier for functional MR. Who would be the candidate for this therapy? The patient with a severe functional MR who fulfilling the criteria suggesting an increased chance of responding of the treatment. So we use the coap-like anatomy. In our region, because we have very low transplant volume, so this might be good option for the patient who still symptomatic after TTMT. And also from the RESHAPE-HF trial, we have the new or broad indication for the FMR patient. Now we can treat less severe FMR patient to like a ELA of a 0.2, and that might have benefit from the MTR also. When should we consider treatment? When the patient who's still symptomatic after truly maximally tolerated GMT. So we should put on medication first, but not wait very long. So normally I would adjust the medication for 1 to 3 months. And if the patient has no response, we consider this therapy. And in some patients, the blood pressure is very low, cannot tolerate any GMT. We can consider this treatment also. And how? So we should build strong heart team, because not only interventional cardiologist, the heart failure doctor, EP doctor, and also cardiac surgeon should share the opinion to choose the best choice for the patient. And also, if we want to do this procedure, we should achieve good result. That means the MR less than 2+. So the luckily now we have the good device that we can achieve the MR 2.1 or 2+. Thank you for your attention.
Thank you, Dr. Mimuk, for your wonderful talk and great job. I think you did a wonderful job for the patients and for his life quality. And there is one question from the audience. Is there still a best range for the LV dimension for your decisions of in deciding tier for functional MR in non-ischemic MR?
So normally we follow the COAF criteria, but some patient with the very dilated LV and the patient has no choice, and also the transplant is not feasible for the patient. We still use the tier or offer the tier for those patients also. But if the lower LV dimension would have the good response compared to the very big or dilated ventricle, and sometimes in very dilated LV. So when we do the tier, sometimes we cannot eliminate the MR completely, because sometimes it can be the pop-out valve when we close all the MR. Sometimes the LV cannot. The afterload mismatch is a problem in a very dilated LV or very poor LV ejection fraction. So that's a problem if we try to treat the very bad LV.
Okay, there is one more questions. What complications are more common in Asian population undergoing TEER?
Yeah. Normally this is quite safe procedure. The serious complication is very low, but we found some like a anatomical difficulty for Asian population. Sometimes the atrial is quite small compared to the Western population, because when we do the MTR, we would have the height, that means the point entry of the LV from the septum to the mitral valve would be like a 4 to 4.5 centimeter height. But sometimes the atrium in Asian population is small, like a 3.5 or less than 4. Sometimes it's difficult, but we can do some maneuver to face with this difficulty. Another point is sometimes the venous diameter is not quite the problem, because its vein can be dilated up to 1 or 1.5 centimeter. The 25 French sheet should be accommodated for all Asian population. And I saw another problem is atrial functional MR, because in our region, sometimes for the atrial FMR, we have very big atrium that and also very tethering of the mitral valve, that when we put on the clip, sometimes make the leaflet injury in very dilated annulus. That's a problem in our region, I think.
Is there any question from the experts?
So obviously, this was a long study, so it took about 8 years, right?
Yeah, 9 years.
9 years. So did the type of the device used in this patient somehow affected the results during this long period?
Yeah. In this trial, they used like a G1, G2, and G3, and some patients use the G4. So I think the evolution of the device that impact to the result, because we know with the newer generation device we can achieve the good reduction of the MR also, I think. But the new generation device is compared to the new GMT also, because they allow to adjust the medication after enroll to the trial. That means after enroll into the trial, they can get more GMT. That means sometimes SGLT inhibitor might more than 9%, because 9% just only the baseline.
Here's one more question. Do you suggest TEER for primary MR with deteriorating ejection fraction? And or do you suggest a non-invasive Da Vinci mitral valve reconstruction by surgeon?
It depends on normally for the primary MR, we recommend the patient with a symptomatic severe MR who has a high surgical risk. That means if the patient still young or lower risk or intermediate risk, we still recommend to do the surgery. But we have to wait for another trial that compare the MitraClip with the surgery in the moderate risk patient that would publish in few years. But for now, I just reserve for the high surgical risk patient only.
Okay. Thank you so much, Dr. Mimuk. So let's move to the next session. I think you need
I'm
to.
sorry for that. I was muted. So our last speaker for today, but definitely not the least, is Dr. Masaharu Akao from Japan. He's Director-in-Chief at the Department of Cardiology, National Hospital Organization, Kyoto Medical Center, Kyoto, Japan. And he's here to talk about asundexian, a factor 11A inhibitor for stroke prevention in atrial fibrillation, the OCEANIC-AF. Is it inferior to the factor 10A inhibitor? We're pleased to have you today, Dr. Akao.
Hello. Thank you, Chairperson, ladies and gentlemen, and thank you for having me. So let me start my slide. Okay, do you see my slide?
Yes.
Okay. Okay, my name is Masa Akao from Kyoto, Japan. So today I'd like to talk about the OCEANIC-AF trial on behalf of the trial steering committee and the investigators. This is my COI. Atrial fibrillation is a common arrhythmia in the elderly and increases the risk of stroke and death. Oral anticoagulants, OAC, are highly effective in reducing the risk of stroke, although they are associated with breathing complications. DOACs, direct oral anticoagulants, are now accepted as first-line therapy over warfarin with lower rates of stroke, mortality, and intracranial hemorrhage. However, patients on DOACs still face a bleeding risk of about 3% per year. Bleeding and fear of bleeding remain a major challenge for DOAC therapy and adherence to treatment, resulting in, number one, undertreatment. Almost 66% of patients with atrial fibrillation and CHA2DS2-VASc score 2 and above are prescribed an OAC at all. Number two, underdosing. Up to 25% of patients on DOACs are underdosed, which might result in higher rates of thromboembolic events. Number three, poor treatment compliance. 1 in 3 patients adhere to their DOAC less than 80% of the time, and the non-adherence is associated with poor clinical outcomes. Thus, there is still an unmet need for DOAC therapy in current clinical practice. Inhibition of activated factor 11A, is a potentially favorable anticoagulation target because this could uncouple hemostasis and thrombosis. Factor 11 is activated after initiation of contact pathway and during the amplification phase after activation by thrombin. Therefore, factor 11 contributes to clot progression and pathologic thrombosis. When a factor 11A inhibitor is used, thrombin amplification is inhibited, which prevents pathological thrombi. And the tissue factor pathway still produces thrombin, which allows beneficial blood clots to form. There are other evidences that support the potential utility of factor 11 inhibitors. It was previously reported that persons with genetic factor 11 deficiency do not have spontaneous bleeding or hematomas and have a lower incidence of cardiovascular events. especially cardioembolic stroke, than persons without factor XI deficiency. Several compounds that inhibit factor XIa, including an antisense oligonucleotide, abelacimab or socimab, and asundexian milvexian, have been associated with a lower risk of bleeding than DOACs. Asundexian is a direct selective inhibitor of factor XIa that is administered orally once daily and has a mean half-life of 16 to 18 hours. In the phase 2 PACIFIC-AF trial, patients with atrial fibrillation were randomly assigned to either asundexian 50 mg, 20 mg, or a factor Xa inhibitor apixaban. Primary objective was to evaluate that asundexian, when compared with apixaban, leads to a lower incidence of bleeding in patients with atrial fibrillation. So treatment with asundexian was associated with a significantly lower incidence of bleeding than treatment with apixaban. Asundexian 50 mg resulted in 92% inhibition of factor XIa activity at trough concentrations and 94% inhibition at peak concentrations. As compared with apixaban, asundexian 50 mg demonstrated 84% reduction in ICH measure bleeding or clinically relevant non-major bleeding. So based on these findings, the hypothesis of the phase 3 OCEANIC-AF trial was that asundexian at 50 mg daily will be at least non-inferior to apixaban for the prevention of stroke or systemic embolism in patients with atrial fibrillation at risk for stroke, and that also powered to determine if asundexian is superior to apixaban for reduction in ISTH major bleeding and net clinical benefit combining stroke, systemic embolism, and ISTH major bleeding. The OCEANIC-AF trial was a phase 3 international double-blind, double-dummy randomized clinical trial that compared the efficacy and safety of the oral factor XIa inhibitor asundexian with apixaban for the prevention of stroke or systemic embolism. High-risk patients with atrial fibrillation were randomly assigned in a 1-to-1 ratio to receive asundexian 50 mg once daily or apixaban. The trial was planned to enroll 18,000 patients. The primary efficacy endpoint was stroke or systemic embolism. The primary safety endpoint was ISTH major bleeding, and the primary net clinical benefit endpoint was a composite of both. Patients were eligible for the study if they have atrial fibrillation with indication for indefinite treatment with an anticoagulant and a CHA2DS score 3 or greater if male, or 4 or greater if female, or a CHA2DS score of 2 if male, or 3 if female, and at least one of the enrichment criteria as shown here, including advanced age, previous stroke, renal dysfunction, OAC naive, and so on. Key exclusion criteria are shown in this slide. They include mechanical heart valve, mitral stenosis, atrial fibrillation due to reversible cause, after catheter ablation or left atrial appendage occlusion-exclusion, recent ischemic stroke, eGFR less than 25, and patients on dialysis. Study results. From December 2022 to November 2023, 14,830 of the planned 18,000 patients had been randomized. Independent Data Monitoring Committee recommended stopping OCEANIC-AF to the executive committee and study team due to inferiority of asundexian to apixaban for the prevention of stroke and systemic embolism. November 19, 2023, sites were notified worldwide of the trial termination. Patients were brought in for trial closeout procedures and to start standard open-label OSC therapy. This slide shows a study flow chart. 16,436 patients were enrolled and 14,810 patients were randomized. The baseline characteristics are shown in this slide. The mean age of the trial patients was 73.9 years, 35.2% were female, and 16.8% had previously received OSC for no more than 6 weeks, and 10% were receiving concomitant antiplatelet therapy, and the mean CHA2DS2-VASc score was 4.3. Overall, 36% of patients had paroxysmal atrial fibrillation. Coexisting conditions were hypertension in 88.6%, heart failure in 46.8%, coronary artery disease in 33.4%, diabetes mellitus in 36.9%, chronic kidney disease in 18.6%, and stroke or TIA in 18.2%. Primary results. During the median follow-up of 160 days, the primary efficacy endpoint, stroke or systemic embolism, occurred in 98 patients, cumulative incidence of 1.3% in asundexian group, and 26 patients, cumulative incidence of 0.4% in apixaban group, with hazard ratio 3.79, 95% confidence interval 2.46 to 5.83. Notably, the incidence of ischemic stroke in the apixaban group was very low, 0.4%, significantly lower than that predicted by the CHA2DS2-VASc score and that observed in the Aristotle trial performed more than 10 years ago. This table shows full results of the primary and secondary efficacy endpoints. Deaths from any cause occurred in 60 patients, 0.8% in the asundexian group, and 71, 1.0% in the apixaban group, with hazard ratio 0.84. Deaths from cardiovascular causes occurred in 48 patients, 0.6% in asundexian group, and 44 in 0.6% in the apixaban group, with hazard ratio 1.09. In the safety population, ISTH major bleeding, the primary safety endpoint, occurred in 17 patients, 0.2% in the asundexian group, and 53, 0.7% in the apixaban group, with hazard ratio 0.32. The composite of ISTH major and clinically relevant non-major bleeding occurred in 83 patients, 1.1% in asundexian group, and 188, 2.6% in apixaban group, with hazard ratio 0.44. The primary net clinical benefit endpoint occurred in 120, 1.6% in asundexian group, and 75, 1.0% in apixaban group, with hazard ratio 1.61. Any adverse events occurred in 35% in asundexian group and also 35% in the apixaban group. Any adverse event leading to the discontinuation of the trial drug occurred in 2.0%, in the asundexian group and 1.6% in the apixaban group. Subgroup analysis. Although not shown in this slide, factor 11 activity at the trough was similar between OCEANIC-AF versus PACIFIC-AF, 8.1% versus 8.0%. The number of patients with primary efficacy events was limited, but there was no differences in factor 11 activity between patients without with or without event, as shown in this slide. This slide shows the results of major subgroups. The inferiority of asundexian in terms of efficacy was consistent in almost all subgroups, including age, gender, renal function, and so on. However, there was a significant interaction between patients with or without prior OAC treatment, OAC experienced or OAC naive. This slide shows event curves of OAC naive and OAC experienced. OAC experienced patients, as presented by the solid lines, showed remarkable difference with hazard ratio of 4.66 between asundexian and apixaban. However, the inferiority of asundexian was not so pronounced in OAC naive as presented by the dashed lines, with non-significant hazard ratio of 1.42. So in conclusion, ladies and gentlemen, over 14,810 patients with atrial fibrillation at risk for stroke were enrolled over 11 months worldwide. Asundexian 50 mg once daily was inferior for prevention of stroke and systemic embolism compared with apixaban in patients with atrial fibrillation at high risk for stroke. The majority of patients, 83%, had previously been treated with OAC. In other words, the majority of trial patients were NOAC survivors. As mentioned earlier, observed rate of stroke and systemic embolism on apixaban in this high-risk population was lower than previously observed. So more research is needed to determine the correct amount of factor 11A inhibition for atrial fibrillation stroke prevention. So there is an ongoing patient risk-adjusted analysis of PK/PD, factor 11 activity, and stroke rates. So near total suppression of factor 11A activity may be required for this indication. Prior use of oral anticoagulants without clinical issues and current medical therapies may lead to lower rates of stroke and systemic embolism and bleeding compared with historical data based on patient risk. Lastly, multiple ongoing studies with factor 11 inhibition in different indications are now ongoing with IDMC oversight. These will be informative to the effect of targeting factor 11 on patient care. We thank all the study team members and participants of this trial. Thank you for your attention.
Thank you very much, Dr. Rafael.
Thank you.
Do you have any questions from the audience? Dr. Rafael, I think you mentioned in your last slide that it's still a question of what's the proper dosing, I think, for the asundexian. So the good thing is that it was superior to apixaban in terms of bleeding.
Yeah, that's right.
In the future direction, what is the plan with the dose? Do you plan? Is there any?
Well, actually, yeah. So as you mentioned correctly, so the dosing is one of the biggest issue in this trial. So it looks like something like a placebo, right? So there is some very low bleeding risk, but almost no effect on prevention of stroke. So the preliminary, so preclinical studies show that there was more than 90% inhibition of factor 11 activity in this dose, but nearly 100% may be required for stroke prevention. And also another issue is that the reliability of the factor 11 activity assay. So the inhibition was not enough for this indication. And as for asundexian, there's no clear future plan for development. Well, at this point, the study sponsor do not think about the continuation of the trial. But there is another big large-scale trial for another factor 11 inhibitor, milvexian, and the trial is now ongoing. So we are going to see what happens.
Thank you, Doctor. You have any more questions? I think we have a question from Professor Sumru. How can healthcare providers minimize bleeding risks in patients on asundexian?
How can minimize the bleeding complications taking asundexian, you said?
Yes.
Well, so there's no very clear data about the bleeding risk of the patients taking asundexian. So at this point, I have no suggestion, but maybe it will be the same as other drugs like pixaban or some other drugs.
Okay. Do you have any more questions, Dr. Wu? You have no more questions or any comments? Okay. So I think that's our final topic for today. Thank you very much, Dr. Akao.
Thank you very much.
Thank you. So as we wrap up today's webinar on the state-breaking trials, I would like for us to ponder on the invaluable insights that we've shared. This is truly an exciting time in cardiology where lots of research output are being published and which will definitely shape the future of our practice as cardiologists. The discussions that we've had underscore the importance of collaboration and to keep asking questions, challenge existing guidelines and therapies, ultimately for the good of our patients. So as we move forward, let's continue to foster these connections and share our findings, ensuring that our efforts lead to meaningful advances in healthcare. Thank you to all our speakers for their expertise. Thank you to my co-chair, Dr. Chok Hai Wu, and to our program director, Professor Jun Lee Lin. And of course, thank you for all the participants online. We look forward to seeing you on our next gatherings. Thank you and have a great day ahead.
Thank you, Baba.
Thank you. Thank you all. Thank you all. Okay. Would you like to take a photo?
Yeah.
Maybe you can open a camera. Timothy, can we have a photo together? You are still here?
Yeah, we done. I done. Okay.
Okay. Thank you. Thank you all.
Yes,
Thank you.
I will
This is
pass
a great
you.
section. Thank you. Thank you. Thank you all.